Okay, so as everybody continues to file in so we can kind of stay on track, we'll go ahead and get started. Welcome to the 2013 Indiana Sickle Cell Conference entitled Sickle Cell Disease, the Ultimate Health Disparity. My name is Keisha Hampton, and I'm the Sickle Safe Newborn Screen Program Coordinator at the Indiana Hemophilia and Thrombosis Center. And I will be your moderator for the conference today. So before we get started with our speakers, I'd like to first introduce the Martin Center Executive Director, CEO. Gary Gibson has enjoyed a distinguished career that features significant positions of authority in the private, public, and nonprofit sectors. Currently serving as the President and Chief Executive Officer of Martin Center, Gary is responsible for leading Indiana's only not-for-profit agency dedicated to sickle cell disease. Under his leadership, Martin Center provides support services to individuals with sickle cell disease and sickle cell trait, provides sickle cell education to the community, and advocates on behalf of those who must live with sickle cell disease. Prior to joining Martin Center, Gary has served in leadership positions at the Indiana Bureau of Motor Vehicles, the Indiana Governor's Office, the Indiana Department of Administration, and the Indianapolis Airport Authority. He also spent several years as CEO of an economic development consulting company, Gibson and Associates. Governor Evan Bayh presented Mr. Gibson with the state's highest honor, the Sagamore of the Wabash, in January of 1997, and then Governor Frank O'Bannon presented him with another Sagamore in January of 2001. In 2004, Gary published an inspirational science fiction novel named New Earth Rising, a fictional novel about extraterrestrials who come to Earth to show its inhabitants the way to a new reality of equality, peace, and spiritual growth. I got to read that. I like that stuff. Mr. Gibson is committed to making a difference in his community. He has served in leadership positions on numerous boards and commissions, including the Martin University Board of Trustees, the Governor's Commission for Minority and Women's Business Development, the City of Indianapolis Marion County Equal Opportunity Advisory Board, Martin Center, the ACE Mentor Program of Indiana, and Aztec Workforce Training and Education Center. Please welcome Gary Gibson.
Thank you, Keisha. Good morning, everyone. Thank you for being here. Good morning. Good morning. On behalf of Martin Center Sickle Cell Initiative, I'd like to thank you all for being here. We have some outstanding speakers that are lined up, and I'm very grateful that they're here. And I'm just excited as you are to hear what they have to say today. We thank them for sharing their time and their expertise with us, and we look forward to following their progress in the future. We've been working for many months to put this conference together for you, and it's our hope that you will leave here this afternoon more informed and more eager to make a difference in the world of sickle cell. Events like this take teamwork, and battling a disease like sickle cell is no different. That's why we are urging all of you to join the chain to stop the pain of sickle cell. Samuel Johnson, the famous 18th century English writer, said it best. The chains of habit are too weak to be felt until they are too strong to be broken. We need you to become a link in this chain so that it can become strong enough to pull sickle cell out of the quicksand of disparity that currently imprisons it. It is this quicksand of the disparity that we must work together to overcome, and meetings like this help us do that. So that is why we have entitled this theme, the theme of this conference is Sickle Cell Disease, the Ultimate Health Disparity. And throughout the day, you're going to hear things that are going to help you understand what we mean by that. So without further ado, it's my pleasure to introduce to you the chairperson of the Martin Center Sickle Cell Board of Directors, Mr. Carl Ellison, for other welcoming remarks. Carl?
Thank you, Gary, and good morning, everyone. It's my pleasure as the chair of the Martin Center Board of Directors to welcome you to this Indiana Sickle Cell Conference. This conference comes at an important time in our nation's history. Bear in mind that we are now at the forefront of major health reform that many of us have lobbied for, called for, thought about for many, many years. We're finally at the point where through the Patient Protection and Affordable Care Act, otherwise known as Obamacare, actually will position the nation to better potentially achieve its national health goals, which calls essentially for all populations to experience health outcome equity. Now, we know that special populations like those in the sickle cell community have always needed special advocacy and have battled the problems of many Americans with just simple things like access to care, can afford the medication. So if the Patient Protection and Affordable Care Act lives up to all of its promises, we finally will have a day where insurance access is not an issue, where access to medications is not an issue, where there's more focus on prevention and on health rather than sickness, and this nation might actually pay more attention to sickle cell. But those of us who've been involved in the health disparity business over the years know that absent advocates, absent loud voices, sometimes the system just doesn't move quite fast enough. So I join Gary and all of our speakers in hoping that today you'll gain information, maybe some inspiration, but certainly be moved to action to help us try to achieve the promise of universal access for our people, but beyond that to help make sure the sickle cell doesn't get lost out there with respect to people's understanding of its importance to people who deal with it, but also of its importance to the nation's health. So thank you very much for your time today. Do enjoy what we have to offer. Thank you.
Okay. Our first speaker for today is Dr. Althea Grant. Dr. Althea Grant is the chief of the Epidemiology and Surveillance Branch in the Division of Blood Disorders of the National Center on Birth Defects and Developmental Disabilities. She does epidemiological research and surveillance on a variety of blood disorders with a special focus on hemophilia, hemochromatosis, thalassemia, and sickle cell disease. Dr. Grant has specifically been recognized for her contribution to developing public health programs and resources for sickle cell disease and sickle cell trait. She serves as CDC's project director for the RUSH program, the first population-based public health surveillance system for sickle cell disease and thalassemia. She also received a commendation medal from the U.S. Public Health Service in recognition for developing programs to improve the health of individuals affected by sickle cell disease. She began her career at the CDC as an Epidemic Intelligence Service Officer and as an epidemiologist in the Division of Reproductive Health, where she worked on issues such as HIV infection among adolescents in Georgia, infant health among Puerto Ricans, genetic and environmental risk factors associated with preterm birth, and the genetics of gestational diabetes. Dr. Grant received a BS in biochemistry from Rutgers University in New Brunswick, New Jersey, and a PhD in biochemistry and molecular biology from the Emory University in Atlanta, Georgia. She has authored and co-authored more than 30 articles and book chapters and has been an invited speaker at numerous scientific conferences and events, including speaking on behalf of the State Department at both the first and third UN World Sickle Cell Days. It's my pleasure to welcome Dr. Grant.
And I want to thank the organizers of this conference for inviting me and giving me a really difficult topic actually to talk about, but I actually love the challenge. When I was invited, I said, oh, sickle cell disease, the ultimate health disparity. That's pretty challenging because many people do not see sickle cell disease in the context of health disparities. And I often have conversations both internally to government and externally about sickle cell disease as a health disparity. And people say, well, how could sickle cell disease be a health disparity? Doesn't it affect mostly only African Americans? And so then that opens up a conversation of why it should be considered. So my goal today is to maybe convince you that sickle cell disease should be included amongst the list of disorders that we really focus on, and when we focus on health disparities and health equity from a national level, and why addressing sickle cell disease and focusing on that could really teach us some really important lessons that will help us not just help people with sickle cell disease, but actually help all Americans in addressing health disparities. So I'm going to begin the talk by first giving a little background about sickle cell disease, just to make sure that everybody is on the same page. And then I'm going to talk a little bit about the history of sickle cell disease in the racial context, just to give you a backdrop of, why this has been such a charged subject in the American sphere. And then I'm going to end by talking about health disparities and health equity and the argument for why sickle cell disease should be considered, or people affected by sickle cell disease should be considered a health disparity population. So just some basic background. So sickle cell disease is an inherited blood disorder where people make an abnormal hemoglobin gene. And in states of low oxygen, that abnormal hemoglobin deforms red blood cells and they stick together. And this causes blockage of small red blood cells. It also causes shortened lives of red blood cells and hemolysis. And that etiology is what really leads to a lot of the major complications we see among persons affected by sickle cell disease, including frequent infection, anemia. We often refer to sickle cell disease as sickle cell anemia because that's a characteristic complication of the disorder, painful crises. Anemia and pain are often emblematic of the disease, and frequently when people think about sickle cell disease, they specifically think about the anemia and pain. But people with sickle cell disease have a host of other complications that can often be life-threatening as well, including strokes, including increased rates of asthma, acute chest syndrome, chronic organ damage that includes renal damage and renal disease, pulmonary hypertension, and the list can go on and on and on. So I just started writing others. So sickle cell disease causes dramatic effects on the health of people living with the disorder. So just a brief mention about how sickle cell disease is inherited. When you get one copy of the abnormal hemoglobin gene from each parent, so that you have two copies, then you have a form of sickle cell disease that we refer to as hemoglobin SS disease. It's commonly referred to also as sickle cell anemia. Sometimes people distinguish when they say sickle cell anemia, they're specifically talking about SS, and when they say sickle cell disease, they may mean all of the forms, including hemoglobin SC disease and hemoglobin S beta thal. If you inherit only one abnormal gene from one parent and a normal gene from the other parent, you usually you have a disorder called sickle cell trait. People with sickle cell trait usually do not have complications or pain or other issues, but under some extreme conditions, complications have been observed, and that's a whole separate talk. And then if you inherit one abnormal sickle gene from one parent and another abnormal hemoglobin called C trait, you have a form of sickle cell disease called SC. Although the phenotype or the expression of and severity of sickle cell disease varies across all of the different forms, people often talk about hemoglobin SC as being a milder form of sickle cell disease. The median life expectancy of those with SC is much longer than those with SS, although people with SC can have very, very severe disease as well. And then if you inherit abnormal hemoglobin S and a beta thal trait from one S and one beta thal trait from your parents, whether that's beta plus trait or beta zero trait, you have hemoglobin S beta thal. Now, hemoglobin S beta zero thal is phenotypically just like SS disease, whereas people often think of the S beta plus being also a less severe form of the disease. So who does sickle cell disease affect? And this is really an important, this is an important part of this discussion, especially as I start to talk about sickle cell in the racial context. Because having sickle cell trait gives you a survival advantage for surviving when you get severe forms of malaria, sickle cell trait or the sickle cell gene is in highest prevalence in areas with high rates of malaria. So if you look at the left side of the slide where you have the prevalence of malaria with the brown being places with high levels of malaria, and you compare that to the right, the picture on the right where you see the prevalence of sickle cell, the sickle cell allele, just the S allele, you can see that there is some definite overlap where places with high malaria also have high rates of sickle cell disease. And because of this concordance, you see high rates of sickle cell disease in peoples whose ancestors come from those places. So whose ancestors come from sub-Saharan Africa, India, Saudi Arabia, and the Mediterranean. What you'll notice from that is that it's not just people on the African continent who may have really high levels of sickle cell disease. If you look at the India dot on the map, you can see that places in India have rates as high as the rates that you see in sub-Saharan Africa. So even the characterization of sickle cell disease as just a black disease is actually a poor characterization. Although the vast majority of people affected in the world come from the African continent or have ancestors who come from the African continent, sickle cell disease can affect people of any race, particularly in the United States, and particularly because of that mixture as well. So domestically, in the U.S., we say that sickle cell affects approximately 100,000 people. We're still trying to find that estimate based on doing some population-based surveillance now. But that estimate is probably around right, so it's somewhere between 100,000 and maybe probably 100 and 150,000. And among newborn infants born in America, we see sickle cell occurring in about 1 in 400 blacks, about 1 in 80,000 whites, and somewhere between 1 in 1,400 and 1 in 36,000 Hispanics. And so I have to say an editorial note about those statistics. We always put those statistics on our website, and I think it's really misleading because even among blacks in America, every state has a different incidence estimate. So when I look at my data from California, the rate is like 1 in 500. And if I go to Mississippi, the rate is twice as high, just among blacks. So all blacks are not created equally because this is a genetic disease and it depends on the genetic ancestry of the black population that you're even looking at. Similarly with Hispanics, the reason the rate varies dramatically as well is because Hispanics who have more African ancestry may have higher rates, whereas Mexican Hispanics or Hispanics with more native ancestry, often we see much lower rates. So over 3 million Americans, we think, have sickle cell trait. We never measure, prevalence estimates of sickle cell trait, but we can come up with that estimate by really looking at newborn screening and kind of the rates that we've seen in African Americans, and then just extrapolate using census data to the whole population and say it's about 3 million Americans. And generally in studies, people see that about 8% of African Americans have sickle cell trait. So I'd be remiss if I start talking about the disparity issue without first talking a little bit about the historical context of sickle cell disease. Sickle cell disease has been part of the American disease conversation for over 103 years now. Sickle cell disease was first identified by Herrick in his paper in 1910, where he described anemia characterized by bizarre sickle-shaped cells, and a dental student in Chicago named Walter Clement Noel. And then in the 1940s and really 1940s through the early 1950s, sickle cell began to be really better characterized from its genetic nature and its hereditary nature. In the 1940s, Neal and Beat both demonstrated that sickle cell disease was an inherited disease, and Linus Pauling famously characterized sickle cell disease in 1949, and the paper is actually in 1951, I think, as the first molecular disease. But it really hasn't been until very recent history that we have started to talk about sickle cell disease at the national level from a programmatic sense in developing programs around sickle cell disease. And that really was initiated when in 1972, President Nixon signed the National Sickle Cell Anemia Control Act. So I'm going to really start the conversation about race, although the conversation obviously predates 1972, but from a governmental programmatic point of view, I'm going to start that conversation in 1972 by talking a little bit about the Sickle Cell Anemia Control Act and some of the good points and what it was trying to do and some of the bad points that resulted as well. So the goals of the Sickle Cell Anemia Control Act were to reduce the morbidity and mortality of sickle cell disease, and actually we have seen dramatic reductions in both of these things and an increase in life expectancy post the Sickle Cell Anemia Control Act. It also attempted to increase awareness by educating the public, and there were some good parts but also some bad parts that happened with the education piece. And then the act was actually supposed to help develop new modes of therapy for sickle cell disease and increase funding for research for new therapeutic modalities. And there have been some successes, but also a lot of failures in that realm as well. The act created funds for mandatory carrier screening and counselor programs, for information and educational activities for healthcare professionals and the general public, and for research training and diagnosis, treatment, and management of sickle cell disease. And although the goals of the acts were virtuous, there had been some major criticisms of the implementation of the act and some of the consequences. So there were basically three main criticisms of the early implementation of the Sickle Cell Control Act. And one was that the act, because of the way it was implemented, often reinforced racialization and stigmatization of the disease. The programs were designed to educate the public and educate, all race ethnic groups theoretically, but really most of the programs actually targeted African Americans, even though sickle cell, as you saw from previous slides, sickle cell disease and sickle cell trait occurs in all racial ethnic groups. A lot of the initial screening programs, a lot of initial education programs were only specifically targeted to African Americans. So many of the early programs missed other ethnic groups. Some of the language that was used, because they were specifically targeting African Americans, was somewhat offensive. This language is from some pamphlets from the New York Department of Health, which was like the first health department to really try to do and target screening. And so in their screening brochures, they had things like all urban, not rural or suburban children should get screened. So as if you lived in a suburban area, that meant you were white and you didn't need to be screened. So there was implicit racism just in that targeting message. Other messaging that was in those pamphlets include all persons not of Caucasian, Indian, or Oriental races be tested for sickle cell trait before applying for a marriage license. So you can see from the previous slide, there's no scientific basis to exclude Indian, Oriental, or even Caucasian races because they could be at risk. But they were excluded often from testing. And then some of the language actually specifically referred to sickle cell disease as a communicable disease. And that led to a lot of misinterpretation of sickle cell disease as not being a genetic disease, and people thought you could catch sickle cell disease. So those were some of the initial criticisms. The other criticism is just a general criticism that we'll always have, and this is American criticism. We like to have freedom about what we will or will not do. But actually, a lot of the initial screening laws were mandatory, so you didn't have choice. So at least 10 states had mandatory screening programs that you could not opt out of. And these programs were not just for newborn screening, but these programs required mandatory screening in preschools, mandatory premarital screening, and mandatory screening of inmates in the penal system. And so that was looked at as too intrusive of government, and also very suspicious since it was done in a very targeted way. So another criticism of the act is that it actually fed the confusion about the distinction between sickle cell disease and sickle cell trait. For instance, many of the early screening programs that were set up used tests that were inaccurate for distinguishing the two forms of the hemoglobinopathies. And so people use solubility tests where you couldn't distinguish sickle cell disease from sickle cell trait. So sometimes people misinterpreted it when they had a positive to think that they had sickle cell disease when they did not. The act often a lot of the screening programs and a lot of the initial implementation lacked clauses about protection against discrimination. And that actually led to people being denied opportunity. And if you are really familiar with, the history of sickle cell trait, then you know that people were denied opportunities in employment, denied opportunities in insurance, and denied other opportunities because of positive results. Then there was also some screening programs that did not offer education and counseling to individuals. So people were not able to really understand the implications of their results. So that's the historical context in which we sit and where things evolve. Now, it has dramatically improved since then, but when the act first passed, there was a lot of kind of racial undertone and context that actually is aligned with the history of disorder. So when we start to talk about sickle cell disease in the context of health disparities and health equity, we can't forget the linkage of race to this whole discussion. So I'm going to change gears for a second and talk a little bit about what it means to have a health disparity, or what is a health disparity. So health disparities are often talked about as either a health disparity or a health inequality. And so the definition and if you go to the NIH website, the definition of a health disparity is that health disparities are differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. And so the key to really understanding health disparities is that it's actually quite simple. If you look at the prevalence, the incidence and mortality, or access to care even of one population, which in this slide is like, say it's the black ovals, it's not equal to the other population, let's say the white ovals. And so a health disparity population, in which I'm going to argue that sickle cell disease can be considered a health disparity population, is a population is a health disparity population if there is a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rates in that population as compared to the health status of the general population. And the reason people often do not get sickle cell disease as a health disparity population is because they think of health disparity only in the population being defined in the context of race or context of a social determinant. So the black circle for them might be black race and white race, or it may be rural versus urban. And if you compare sickle cell that way, it's hard to see the health disparity. But if you put sickle cell disease in the context of people with sickle cell disease versus people without sickle cell disease, or people with sickle cell disease versus people with another chronic disease, then you can see that sickle cell disease in itself is a health disparity population. And so forget about the question of incidence and prevalence when you define sickle cell disease from a prevalence of the disease itself. What you're really talking about is incidence and prevalence of the morbidities associated with the disease and how they affect that population. So I'm going to talk a little bit about that. So if you look at morbidity as your outcome and you compare sickle cell disease to the general population or sickle cell disease to another population, then you can see that sickle cell disease has extreme level of morbidity compared to the general population. So about 20 to 30% of children with SS experience stroke and cognitive impairment. And in fact, we are just submitted a paper for publication, one of my fellows, where we looked nationally to figure out where sickle cell ranks among stroke incidents in pediatric. And sickle cell is the leading cause of pediatric stroke among African Americans. It's like 29% of the ischemic stroke of the whole population of African Americans is due to sickle cell disease. So when you put sickle cell disease in the context of that, then wow, that's a dramatic disparity. If you talk about sickle cell disease in the context of what students experience in school, so you can see that due to frequent pain crisis, children with sickle cell disease miss an average of 18 days of school each year. So if you talk about those children compared to other children, they have a disparity in their access to school and their ability to move through that system and achieve often. And then if you looked at, say, women with sickle cell disease, if you looked at a context of an outcome like pregnancy outcomes, so women with sickle cell disease have an increased risk of antenatal hospitalization, increase of preeclampsia and IUGR, increase of length of stay, and if you look more closely at the data, also increased risk of mortality and all the adverse outcomes that pregnant women really have. People with sickle cell disease have that, several-fold greater. And so if you talk about the context of morbidity as the outcome, there's a dramatic disparity there. If you talk about the context of mortality, which was the other indicator mentioned on that slide around disparities, it's clear that there's a disparity in rates of survival. And so if you look at the blue line on the graph, after the Sickle Cell Anemia Control Act, the blue arrow points to kind of around where it started. Yes, we saw a dramatic increase in survival of individuals with sickle cell disease. But what we also see is that there's a still 3-decade gap in life expectancy or median survival compared to other Americans. And so although we've made dramatic strides, there's still a dramatic disparity in life expectancy. And so when we think about health disparities, because health disparities is only about a difference. And a lot of things can underlie that difference. And another reason why people often discount sickle cell disease in the context of health disparities is because they say even if you define the population as sickle cell disease versus everyone else, well, it's biological and there's nothing you can do about it. And they attribute it to the etiology of the disease and don't acknowledge that there are social factors actually underpinning those adverse outcomes. So there's several causes of health disparities. One potential cause could be social determinants of health. That includes things like gender, socioeconomic status, employment status, educational attainment, food security, etc. Another cause of health disparities could be behavioral determinants. Do you smoke? Are you overweight? Are there things that you're doing that are making your health worse than the other group? And then another cause can be environmental determinants. Are you exposed to lead? Are you living in an environment that's triggering your asthma? Are you working in a safe or unsafe workplace? And then finally, and this is from, the Minority Health website, and this is why I added this, they often characterize genetic disorders in the context of mainly having a biological and genetic determinant. So they include that to include things like family history of heart disease or inherited conditions such as hemophilia and cystic fibrosis. And the red part is not from the website. I added that because if you're going to add hemophilia and cystic fibrosis, in their context, they're also adding sickle cell disease. And so they're thinking, okay, there is a disparity, but that disparity is primarily attributed to biological and genetic determinants of health. And I'm going to argue that that's not quite true. So there's equity issues that really contribute to the disparity in sickle cell disease. So let me define health equity because it's slightly different than health disparity. So health equity equals an absence of systematic disparities in health or in the major social determinants of health between groups with different social advantage or disadvantage. And those social advantages or disadvantages can be wealth, power, prestige. Thus, health inequities are the presence of such difference. And so not only could one argue that sickle cell disease is a health disparity population, one could easily argue that there are dramatic health inequities with respect to sickle cell disease. So this is a slightly different definition, but it helps us frame it. It says health equity is the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historic and contemporary injustices, and the elimination of health and healthcare disparities. And I really like that definition because it challenges us to value everyone equally. So when you put sickle cell disease in that context, even if you're comparing sickle cell disease to another disorder, you can ask, why am I not valuing people with sickle cell disease the same as, so if you're funding people differently, if you're giving this person $1 and this person 10, it shows that you're not quite valuing them equally if the magnitude of their disease and their health burden is very similar. And that actually helps us frame sickle cell disease as an inequity issue. And I would argue that sickle cell disease should be declared a national health disparity. And so from that same website on Minority Health and HHS, it says that a national health disparity is a particular type of health difference that is closely linked with social or economic disadvantage. Health disparities adversely affects groups of people who are systematically experience greater social and or economic obstacles to health and or clean environment based on their racial or ethnic group, their religion, their socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation, geographic location, or other characteristics historically linked to discrimination and exclusion. And so most of you are familiar with this really sentinel paper by Smith and colleagues that really compared sickle cell disease to cystic fibrosis and underscored the inequity of investments made in the two disorders. And so when you look at sickle cell disease versus cystic fibrosis, you see that you can't make an argument that cystic fibrosis is more common and therefore it needs more investment because sickle cell disease is actually more common in the U.S. You can't argue that there's equal financial investment in research because when you compare the funding, at that point, the funding dollars from NIH, you could see that cystic fibrosis had, at least 3 times more NIH funding per person with the disease. And then if you look at the number of federal grants, cystic fibrosis clearly had more. And even if you took it out of the federal arena and just looked at private funding, and this is still true today, the numbers aren't the same, but the disparity still exists. There's much more tremendous private support for cystic fibrosis, and their foundation had hundreds of millions of dollars compared to the revenue of the National Association that represents sickle cell disease, which is SCDAA. And so when you look at that kind of total funding and research support, it's obvious that there's a disparity here in investment. But I don't actually have to leave my office to see a disparity in investment because I work with this disparity and I struggle with this disparity, and I should say, make sure you look at the disclaimer on my slide that these views do not represent the agency. But want to mention that I really don't have to leave my office to see the disparity, because I'm fortunate that I get to work on a lot of disorders, and I meet so many people, and I get to serve a lot of people who have blood disorders, not just sickle cell disease. People often think of me as the sickle cell disease woman, but I feel really strongly about all the disorders I work on, but I also acknowledge that there's a disparity in our funding as well. So the three major diseases that I work on right now include hemophilia, thalassemia, and sickle cell disease. So if you were to look at the population, you can see that hemophilia, that we think there's about 20,000 or so people in the U.S. Thalassemia, this is not all people with thalassemia. These are, what people estimate for severe forms, and this estimate is probably totally wrong, but it's still pretty low. So it's around 1,000. And then if we looked at people with sickle cell disease, it's about 100,000, so 5 times more than the population who has hemophilia. And if you look at CDC's congressional funding, this was from 2011. It was about $16 million for hemophilia. It was about almost $2 million for thalassemia, and it was 0 for sickle cell disease, and it's still 0 today, and it has always historically been 0. So just in my office, I face this challenge of disparities, because I want to serve all these populations really well, but I'm not convinced I have the resources to do a good job with all of them. And then the other issue is that if you look at, and I'm really excited that now there's tremendous investment from pharmaceutical and private sector, and there are hundreds of therapies in clinicaltrials.org, but that hasn't always been true. And so historically, there's been a lack of investment in developing therapies for sickle cells. So that's why today we really still only have one FDA-approved drug for sickle cell disease. So those are the inequities in investment. There's an inequity in access to quality care. And so if you look at NIH's, some of their brochures and some of CDC's brochures, I'm going to admit I have no idea where this number came from, but we always quote that fewer than 10% of Americans with sickle cell disease have access to specialized treatment centers. I don't know if it's 10%, but I know it's not many. So we know that there's a problem with care, that there aren't these organized treatment centers to serve the population. And if you compare that, I work on hemophilia, we estimate from our surveillance data that about 70% of Americans with hemophilia receive at some point within a certain period, usually within 3 years, receive care at a specialized treatment center, which is called the Hemophilia Treatment Center, that it specializes in providing appropriate care for them. And then even if you look at when people do make it to care, there's an equity in how they're treated once they get into that system. So this is a nice paper by Ellen Fung and Elliot Fajinsky's group, which looked at iron overloaded patients with sickle cell and compared the monitoring that they get for iron overload to patients with thalassemia. And obviously, if you're transfusion dependent and you're iron overloaded, you can have very severe complications and potentially death if your iron is not controlled. So it's really important that you're treating patients equally. And so they found that monitoring wasn't happening equally, that liver biopsy for routine iron monitoring was 3-fold greater for thal patients versus sickle cell disease. That screening for iron-related organ injury, including echoes, was 2.6 times higher for thal versus sickle cell disease. And that all these other tests that monitor, that are for monitoring iron overload, in every single one of them, it was much greater for thal patients than for sickle cell disease patients. And so even the quality of care that people get isn't exactly the same. Oops, and I think my thing got stuck. Oops, sorry. Oh, there we go. Hold on, let me just redo it because it got stuck. Okay. And so the other characteristics of inequity in quality of care for sickle cell disease that are well characterized in the literature include and well discussed among patients and families in every meeting that you go to is that people with sickle cell disease experience longer wait times in emergency rooms than a lot of other patients. They're often characterized and stigmatized as drug seeking, and there are disparities in pain management, where often they feel that they're not getting adequate pain management because people are characterizing them as drug seeking. And then a recent study showed that even with respect to trait, that parents of children with sickle cell trait were less likely to receive genetic counseling than parents with cystic fibrosis. And so there's inequalities even when people do make it to a care system. And so what is the result of some of these inequities that we see for sickle cell disease? Well, some of the results are that right now we really lack a lot of knowledge about the disorder. We lack information about the risk and complications. One of my favorite quotes was from Dr. DeBond when I was first starting my surveillance system, and I asked him what some of the things were we should look at. He said, you have to look at mortality. And I said, why do I have to look at mortality? You don't have to convince me because I know it's a public health indicator, but why is this like absolutely have to do it? He said, because we don't know why people die. When you look at the mortality data that we collect nationally, most people are coded for death as sickle cell disease, which technically doesn't kill someone. It's the complication, and the complications in the mortality data are not characterized at all. And he was like, until you can tell me why patients die, I don't know how to keep them alive. And then, we have a lack of knowledge around the patient demographics. And one of the things that we've been trying to figure out with Rush is, how many patients are there? Where are they located? Where should the services be? If you don't know where people are, you don't know where to provide services for them. So we're looking at the geography of the population. We're looking at the culture of the population. One of the things we found when we did our New York data is that more than half of the new cases were from immigrant populations. And that means that we have to target our education and our outreach very differently than if we're talking about maybe a non-immigrant population in the South or something. And then healthcare needs of the patients are varied. As you could see from the original slide, people with sickle cell have a lot of complications, and we can't just treat the pain or just treat the anemia. They need a host of healthcare providers to really have a multidisciplinary approach to their care. The other thing that we have because of these inequities is we have really a lack of access of quality care for adults. We don't have a system of care for people with sickle cell disease, and people often drop out of the system or get lost in the system. And we have a lack of utilization of effective treatments. We have hydroxyurea, which is the only FDA-approved drug now, but even that is poorly utilized. And people are some people are afraid to use it. People have concerns about safety, but people aren't necessarily getting all the evidence and information they can to make informed decisions. And so a lot of people who actually get on hydroxyurea can say that it really helped them, or it actually reduced their pain crises, and evidence show that. But despite that, estimates are that only somewhere between 10 or 20% of people are actually on the drug. And generally, we have a lack of awareness in the general American community, but we also have a lack of awareness among providers and among patients. And what does that result in for us? Well, that results in a lot of things. One of that results in mortality that cannot be explained by biology. And so if you assume that the difference is only due to genetics, then you would almost expect some linearity in the growth of complications for the patient population. But that's not, this slide could be mortality, this slide could be ER use, this slide could be hospital utilization, but no matter what you put in this graph, if you compare people in the pediatric stage, like 15 to 19, to people in the early adult stage, although their bodies changed, they didn't change that dramatically. You always see a 3 to 4-fold increase in mortality or hospital utilization or ER use. And that's really because of the social inequities in the disease, not just because of biology. And so what that means for us in America is that we see, dramatic use of hospitalization, particularly for the adult population. This is data from 2004 from HRQ, where they had just among adults, which even if you assume that adults are about 60% of the population, so let's say 60,000 adults, you had 83,000 hospitalizations. The total hospital cost for hospitalizations was over $488 million. Adults accounted for 66% of hospitalizations, and each adult had about 3 emergency department visits, typically due to painful episodes. And then importantly, from a systems point of view, the bulk of that cost was paid by public insurance programs like Medicaid, which accounted for 66% of the payment, and 13% being paid by Medicare. So almost 80% of the population being on public insurance. And then if you looked at emergency department visits overall, in a given year, there were over 200,000 emergency department visits that were associated with sickle cell disease. And for individuals with sickle cell disease, they had frequent hospitalizations and rehospitalizations. And for healthcare costs generally, that equals to about somewhere between $1 and $2 billion in annual health care costs. And so if you look at Medicaid patients, the health care costs are about $1,400 per month. And the annual costs for adults versus children is threefold greater. So when you become an adult, your medical costs triple because of the graphs in that slide where you see a lot of increase of ER use and hospitalization among the adult population. And so we did a study where we looked at mean medical expenditures for children with sickle cell disease in 2005, and we saw that there was about $11,000 per year for those enrolled in Medicaid, and about $14,000 or $15,000 a year for those enrolled in private insurance. And so what do we need from a systematic approach? Well, somehow we have to figure out how to provide real quality specialty care for the adult population. We often do much better in the pediatric population, but for adults, there's often not even an adult provider in their community, so they often transition to care providers who are not knowledgeable about how to provide care for them. We need the coordination of health service and other services. People are more than their disease, and they often are living in the context of poverty or other issues. They may need social support. They may need support on how to get insurance and managed insurance programs. One of my hardest days at work about a year ago was when a patient called me from Texas and said, could you help me? I don't have any health insurance and I'm having a pain crisis. And I just saw you at a meeting and I had your card, so I called you thinking maybe you knew where I could go. And I struggled for a week trying to find some place for this young woman to go. And I think if it was that hard for me, how hard is it for her? And I was calling these hospitals saying, this is Dr. Grant. But, if you're just Mary Jones, are they picking up the phone? Was the question I was asking myself. So the other thing we need is accurate estimates of health indicators, including prevalence, mortality, and health utilization. We need knowledge of risk factors and complications over the lifespan. We definitely need education in the community awareness, not just of people affected by the disease, but of the community that needs to support them. Because people with sickle cell disease live in a community that often needs to change certain things to address their needs, whether it be changes in school and educating teachers or educating people who have to help them navigate their life. So the other thing that we need is increased utilization of effective treatments like hydroxyurea. We definitely need updated uniform clinical care guidelines for how to manage these patients so that when they go to providers who may not be educated about sickle cell disease, that they have a reference to go to figure out what type of care to provide. And so NIH is working really actively on this now. And then we need healthcare quality indicators so that the standards for how care should be provided across hospitals, across clinics can be the same. And so so that people are being measured and accountable for the quality of care that they're providing people. So I'm going to end with 2 quotes that I really like. And of course, most of you are familiar with Dr. King's quote, which is, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. But my other favorite quote is actually from our CDC director, who I have to give a lot of props, has been really one of my champions for sickle cell disease. He had a really close friend that he lost to sickle cell disease, and he's been very supportive, even though we don't have funding. He looks the other way when he sees me working on sickle cell disease, so that I can continue to do what I do. And he said to me, at CDC, we define the unacceptable. We have to collect data. We have to collect information. And what he meant by that is you have to put these disparities in full light so that people can say, this is unacceptable. And he said, your job at CDC is to define what's unacceptable for everyone. So thank you. And I'll take questions if people have questions.
Okay. If we could get Gary Gibson up to present an award to Dr. Grant.
Well, first off, let me just say thank you again, and if you would, give her another hand. Dr. Grant is here with us today because in September of last year at the Sickle Cell Disease Association of America conference, at a breakfast, continental breakfast, I approached her. And I said, Dr. Grant, I'm working on a white paper called Sickle Cell Disease, the Ultimate Health Disparity. I've done some research, and I don't understand why sickle cell disease is not recognized as a health disparity. And I asked her, what did she think? And she said, it should be. So when she said that, I thought that you would be here when we have this conference. So thank you. I hope you remember that moment.
Yes,
but
I remember it.
It was definitely meaningful for me. We would like to just give you a little token of our esteem. We're a small agency, don't have a lot of money, and we know that you can't accept a lot either.
Right, I was going to say, it can't be more than $20.
Right. So we'll look the other way and say it might not have been over $20, but we'd like to just thank you for your...
Thank you. Thank you.
Thank you.
Okay. Next, we'll have up our patient panel. So if we could get the patient panel members to come up and find your name. And as they give them the chance to come up, each patient panel member will have about 5 minutes to discuss topics that they've chosen to, for the audience. These individual presentations will be followed by a question and answer session. And after I introduce the panelists, they will each tell us a little bit about themselves and what type of sickle cell they have. They'll discuss the challenges faced, including school, work, accessing healthcare, and community resources, and then they'll share personal success stories. So on the end, we'll start on the end here. We have Marsha Jackson. Then we have Darlene Ransom, John Gamble, Cheryl Richardson, and I think that's it. Okay. Okay, so if we could start with each person, you can start on either end, whoever wants to go first, by telling us a little bit about yourself and what type of sickle cell you have.
Great, thank you. Good morning, my name is Cheryl Richardson. Is that better? Okay. Good morning, my name is Cheryl Richardson, and I am the mother of a young adult who has sickle cell. He has SS disease. I am married 29 years. We actually have 2 children. The second child, who is an 11-year-old daughter, Olivia, is just a trait carrier. started with Riley Hospital. Actually, we started with Martin Center back in 1998. My son Peter had crisis up until he was about 8 years old, and unbeknown to us, he started to have silent strokes. And it was his school teachers who figured out that there was an issue, because they were very used to tracking all the children, knowing what skills they've had mastered and non-mastered, and he was an A+ student. He came back to school and he had forgotten everything he had learned a year prior. And I remember them calling me and saying, please pick him up, take him to the hospital, something's wrong. I'm trying to figure out what else you all might want to know. Well, in this particular disease, I've been very fortunate because we are a 2-member household working family. And so I haven't had to, I've had some economic issues, but not as many as other people that I talk to. And as far as the school system goes, I've had to go in there and literally train each and every one of his teachers about what was going on with sickle cell, what factors to look for, when to call me. And once it was established that he actually had strokes, we had to find someone who could actually help us figure out what his learning style was and go into the school system and help teach them how to teach him. So.
Okay. Thank you.
Hello, I'm Johnny Gamble from Peru, Indiana, born and raised back in the early 50s, so you can do the math and kind of figure out about how old I am. I guess I was fortunate in I didn't know I had sickle cell disease until I was 25 years old. By that time, I had served a military career, and then I went into law enforcement after college. I think my greatest asset was the support that I had from my family. 4 wonderful grandparents, 2 brilliant parents, and 4 outstanding siblings, and now a beautiful young fiance, soon to be Dr. Talisha Mayo. And go ahead, stand up, let them see who you are. I haven't had a lot of the problems that a lot of sickle cell patients encounter. I know early on my parents, instilled in me that they weren't going to baby me, and it would come a time when they weren't around and I was going to have to deal with this by myself. So I became the tough guy, and I trained, I did everything I could to make myself stronger, and I developed a mindset that I would overcome sickle cell once I knew that I had it. I was diagnosed with rheumatic fever. So all the school children, they called it rheumatic fever, so they thought I was like romantic. So I don't know where they got that. I saw the slide where it said the average was 18 days of missed school. 3rd grade, which I failed and thought that I was dumb because I failed. For whatever reason, I still remember that report card where it said I missed 78 days of school. So in the 5th grade, I found a best friend from Greece who told me that, I wasn't dumb. So from that point on, I competed in school, graduated from high school, college, and I just became obsessed with achieving. And to this day, I still strive to be the best in whatever I do. Very competitive in every aspect of my life. So I guess that's it.
Good morning. My name is Darlene Ransom. I have SS. As John said, back in the 50s, when I was diagnosed, I wasn't actually diagnosed until I was about 5. I had to literally learn how to walk again. I had gone into a coma. they had diagnosed me with leukemia, cancer, because they really didn't understand or know what it was that I was going through. But after they discovered what it was, I was not able to participate with children, play and act, live an active life until I got older. My parents really cared. After they found out, they made sure I had the best of care with the disease, and they found out everything about it to help me along the way. I was fortunate enough that they didn't care. I wasn't going to miss no days in school. I would come home crying a lot of time, aching from pain, walking to school in the snow and stuff, hands aching, but I still had to get up the next day and go to school. So therefore, they instilled in me at a young age that this disease was a part of me. I was not a part of it. So therefore, it did not control me. I had control of it. And therefore, I could achieve and do what I want to do. And therefore, that's what I did for the rest of my life. I went on and I graduated high school with honors. I graduated college. It may have been later on in my life when I graduated from college, but I graduated with honors. I became a model for some years. I traveled extensively, so I still continue to achieve to do the things that I want to do. So once again, it's not a disease where we have to lay down and let it take over our lives. We can live normal lives.
Good morning. My name is Marsha Jackson, and I have SC disease. I was diagnosed when I was 8 years old, and I'm also back in the 50s. And I also missed more than 18 days of school per year. But I stayed on track. I graduated with my class. It was diagnosed due to a lot of pain. I couldn't walk, and I had a lot of high fever. So they finally ran a lot of tests. They also tested me for lupus, but they found out it wasn't lupus and determined that it was SC disease. I am one of 4 children, but I do have a brother that found out when he was in his 40s that he also has SC disease. So it is a disease that you go to the hospital and they think that you just want drugs, but you're not there for drugs because you're in pain. So it's something that we have to live with.
Okay. Now I have a few questions, but I'll open it up to the floor if you guys have any questions for the panelists.
After he was diagnosed, I went to Raleigh Hospital and got all the information that they had. So was never really involved with a geneticist, but we were given all the information. Of course, I went and looked it up. But.
Okay. Right, Dr. Shurney.
My question is for any of the panelists, but I had the experience of having a group of children talk to me about sickle cell disease, and I was talking about the idea of sharing the fact with your friends that you have sickle cell disease, and they just went off on how they felt it was nobody else's business, and that it almost gave me the sense that they were ashamed of having sickle cell disease, and they didn't, and they were adamant about it. I had one guy even leave the room because he didn't want to talk about having sickle cell disease with anybody. And I wondered if you had similar feelings or if you had advice to help them to feel more comfortable, or how would you advise a young person now having gone through it the way you have?
Well, I didn't have problems with knowing that I had the disease. Like I said, I didn't know I had sickle cell disease till I was 25. And even then, and even to this day, I have classmates that will ask me, how did I catch it? I didn't know you had that when you were young. But I've never had any problems knowing that I have the disease or letting anyone know, because normally that gives me the opportunity to tell them about the disease. I really don't know what advice I could give a young person, you know, that encounters that, since I didn't firsthand.
I used to, well, by me being a part of the Martin Center, used to be known as the Sickle Cell Center, I used to talk with a lot of teens, and they had the same. They were on a road of destruction, as I called it. And I would just ask them, because a lot of them, when they first see me, they didn't know I had sickle cell, and I asked them to look at me. And did they think that I had sickle cell? And they said no. And I advised them that, yes, I did have sickle cell, but I did not get where I had gotten on the path that you guys were going, because as I advised them, that my parents advised me, it's a part of you. You're not a part of it. So therefore, you still can live a productive life and go on. And you shouldn't be ashamed of something. I looked at it as my life as a gift. It motivated me to go on, to do more. Because you can still live. You know, they were under the impression that this was a death sentence for them. And a lot of them would just destroy their lives, you know. But after I would talk to them, a lot of them did better, you know, and it was a sense of encouragement to them.
You don't want people to feel sorry for you, and half of them don't know why you're missing school. But if they know that you have a disease, they look at you different. So you just don't really tell them. That's probably why they don't want to tell them. But like everybody says, it's just something you have to live with. So let them draw their own conclusions, but you just go on and live a normal life as possible.
I think one thing that did help me, I was a Riley baby. I was born with a cleft lip and palate. So from 6 months old to 18, I was here twice a month, you know, all of those years. So anything anybody had to say kind of like rolled off my shoulders. I can remember as I grew older, there were people who told my mother that they should have put me in the circus, you know, in the sideshows because of my birth defects. But that kind of paid off for me, because after I graduated from the police academy, I remembered those people, and I found a way. I got back at them. I arrested every one of them who told my mother that.
Question in the back.
Well, thank you all for speaking. I'm a physician, and one thing I found is that people don't know the difference between SC and SF. And I'd like to know, Mr. Gamble?
Yes, ma'am.
Are you SC disease or SF?
I have beta thal.
Okay, beta thal.
Yes.
And I think that for those who don't know the difference, there is a difference in how it manifests. So one of the things I would like to ask of the panel, people on the panel, is do you notice a difference in how your disease acts versus SS disease?
Well, I have SC, and they say it's not as powerful as SS, but you wouldn't know it because the pain crises are the same. They hurt. But SS is usually in the hospital more than SC. Their pain crisis, they require more blood transfusions, but it's usually SSC can be controlled more on narcotics and liquids.
I have SS disease, and I really wasn't in the hospital after I was diagnosed when I was younger too much. I was in the hospital. I had an episode when I was 18 because during the time I was growing up, they really, like I said, they really didn't know what it was. So they would diagnose it as gas pains or whatever, you know, because they didn't know what to give me. Actually, the doctor had me drinking Mogan David wine, you know, for my blood, you know, just a cup every day, you know, for my blood. And so, but after that, I really wasn't in the hospital much. So I think it really depends on your environment. It depends on a lot of things as how your disease affects you. Because with any disease, it's gonna affect each person differently.
I guess for me, when I feel a crisis coming on, you have two options. You can either let it happen or you can try to fight it. And I try to fight it as, you know, often as I can. So a lot of times I'll start doing a workout, start doing push-ups to try to mentally overcome it. Because if you give in to it, that crisis will be a lot worse. And I don't know if there is a difference in the pain level. I have a nephew with SS, and we often, you know, back and forth about how bad it hurts when it's really hurting. And I don't think there's a difference in the pain level. And I think only another sickle cell patient can really tell you how bad it's hurting. But if there's anyone in the room who wants a demonstration as to how much it hurts, I can show you. We had a demonstration at the State House, and I brought that attention to a couple people, and they weren't ready for it. So anyone want to step forward, I can show you.
Well, my son has SS disease, and I also have a brother with it. But we have a young friend who has SC. And I would notice that they would both get sick around the same times, like when the extreme weather changes, extreme hot, extreme cold. But the differences was that my son had started to take it to a different level when he started to have the strokes and some of the other issues that came along with the sickle cell. Now, he has not been hospitalized on a regular basis since he had strokes because he's on a treatment plan. And he gets apheresis every 5 to 6 weeks. And so with the care that he was getting at Riley Hospital, he's now being transitioned to adult. They keep very strict records on where his blood count is at, what it's doing, whether he needs to come in earlier for a blood transfusion. So during his high school years, he only missed school maybe on the day he was having a blood transfusion and was not out for crisis. So, but in addition to that, my son developed a condition called moya, where the blood vessels in the brain constrict until you lose memory. And by the time he was in 8th grade, he was unable to remember anything he had learned in school that day. So he had double brain surgery, where they rerouted the blood vessels so new ones could grow. And I believe he had that they had to do it 2 separate times, one side each month. He had it done in June, had it done in July, and entered high school in August, and was an honor roll student. So.
Okay, Dr. Iffy.
Dr. Iffy from Atlanta, you guys had mentioned earlier that if teenagers are when they're going to die, or they think they're going to die early. And I believe that the message about sickle cell disease in the 70s was that they die early. Are you finding that they're relearning the new message and they're hearing about the older adults who are living with sickle cell disease into the 60s and 50s and 70s? Or do you still think that teenagers feel, and parents think that their child is going to die as a teenager?
I don't feel that the parents believe that any longer. Now, I have a few teenage friends who did die, but a lot of times they didn't want to go with whatever the treatment program was. And when they decided they wanted to live, it was really too late to prolong their life. So
I don't encounter that, but I do know for myself, life expectancy was 25. So when the gentleman from the Martin Center came by and told me that I had sickle cell, I was looking at the calendar daily, thinking it was my day to die, because I was 25. So I was scared to death.
I really don't think they think it too much, but then I have encountered some that still do, but it's not as many as it was back then. Because of today's technology and stuff, I think, it's a better perception of it. And, they have a better chance now than they did back then.
Until the day I died doing research on trying to prevent sickle cell crisis. Because, of course, a mother doesn't want to see her child and children continuously suffer with sickle cell. What I want to know is, have you found that any types of food or anything like that helps oxygenate your blood? Because I've read a lot about how the green vegetables and making smoothies with nutrients and vitamin E's and all those types of things are antioxidants are really good for the blood. Have you found that any particular food has helps, or if you're using whole foods, or but I know fast foods and all those type of processed foods is really not good for the blood.
I have never been really on a particular diet, but I do eat a lot of fresh fruits and vegetables, smoothies. I love fruit. I can eat fruit for breakfast, lunch, and dinner, and so I find a lot of times that sodas or anything with red in it will cause, red dyes or anything like that may cause, different reactions and stuff. So I think we just have to, it just depends on each person, on how you eat and how you take care of yourself. But I really haven't been on a particular diet. If I want a hamburger every now and then, yeah, I'll make my own, or whatever, but, not really too much.
I am absolutely the wrong person. I eat ruffled potato chips, French onion dip, nutty bars. I eat junk. I know I shouldn't be, but that's what I eat. Well, I eat some good foods because the boss gets on me, but when she's not at home, I got a cabinet full of junk, so don't listen to me.
Well, of course, we try to eat healthy at the house, and we cook most of our meals. But with my son being a young adult and going out and purchasing his own, that's another issue. So he eats basically whatever he likes.
Question in the back. Then we'll take that.
We were fortunate enough to have our daughter diagnosed at birth, first in Michigan, then we moved to Pennsylvania, and now we're here in Indiana. So my question is, have you always lived in Indiana the whole time while you were diagnosed, and have you seen a difference in information and care in the different places that you might have lived after you were diagnosed?
Good question.
Okay, I was born in Ohio, and doctors there did not know anything about sickle cell. When I moved to Indiana is when I started getting care, but that was later in life. I did move to Phoenix, Arizona, which the weather did help, but doctors still are clueless. So even though the weather helped, you wasn't getting the medical help that you needed.
I was born, raised, and bred right here I left when I got married and lived in Vegas, but I was fortunate enough at that time to find a doctor that knew about sickle cell, so I really didn't have any problems with sickle cell, and basically here I've never had it. The weather, yes, is a difference. In the warmer climate, I did much better, but here with the weather being up and down, you just never know how it's going to react.
I have not really sought out medical, help for my disease. The only thing they can really do for me is treat me for pain, with drugs. So I found that I take a lot of hot showers, heating pads, dressing properly is the best thing for me. So I don't do the drug thing at all. Too many other things come along with taking the drugs for me. So I can't say there's a difference in the treatment in any state that I've lived in because I treat myself.
Well, we've born and bred here in Indianapolis, been here all our lives, and immediately when I found out he had sickle cell disease, I immediately went to Riley Hospital. So the care has always been there for us.
Okay, question in the front, and then in the back.
My son has SS disease, and he's still a baby. He hasn't had any crisis yet, but for you, that your son has SS disease as well, do you think it's best for me to go through all the treatments, even though I might feel something might happen, like something like with the brain or the brain surgery or the stroke?
It depends on what treatments you're talking about and where you're getting your care at. So if I was you, I would arm myself with resources, contact the Martin Center, come to the support group. They got people there who can help walk you through it and listen to what their experiences are. And I don't know where your doctors are at. Are you here being seen here at Riley Hospital at the clinic?
Yeah.
All right. That's a good starting point.
Oh, right here, Dr. Hassel, sorry.
I'm Kathy Hassel. I'm from Colorado, where we do take care of folks with sickle cell. You add weather to altitude, let me tell you, it's a good benefit.
Yeah.
And I've been taking care of adults living with sickle cell disease for 20 years, and even now we tend to understand the experience. But I've observed and worked with a lot of folks over time. And often when we walk out into the hallway, I've been to many conferences like this over time, this is excellent. And people say, well, those are the exceptional folks. Those are the people that, fought it off, or they had supportive parents. And often we're told that perhaps you don't represent the true experience of many, especially adults living with sickle cell disease. But I'm not sure that's true. And I'd be interested in your sense about, for people that you know living with sickle cell disease, other adults, how many people are really getting about their business, doing their things, versus those that are, the disease has them. They don't have the disease and are living with it. I'd be interested in your impression as you walk through life, how many people can get to a place like you've gotten to.
Oh, wow. I don't know how to answer that. Oh, wow. I look at my nephew who has SS. He's in the hospital probably every 5 weeks. And some of it I don't know. He's a radiologist at Methodist, so I don't know if it's the cool conditions in which he works. I don't know, but that's the only other person that I have to look at other than the guys that are in the support group with me. And it's just hard to answer how anyone else, can deal with it. I just know how I did it and how I do it, and I don't recommend it for anybody. But I really don't know how to answer that. I'm sorry. Yeah.
I'm with John. I have one other close friend that has sickle cell, and she lives basically just the way I do. We just go on with our lives. And other than the folks in the support group, we realize that there are those that are worse off than us, because as I said before, each person is different. And so therefore, even, with the hospital experience, I never did go in the hospital a lot until recently, the past year or so. But basically, as the doctor had mentioned before, it wasn't really my sickle cell that I was in there. It might have been the complications that brought a crisis on, but it wasn't from the sickle cell. So I really can't, we can't answer that, Okay, take that one.
That is a hard question to answer. You want to be alone a lot because nobody can really do anything to help you. So you just fight through the pain, try to stay as warm as possible. And somebody else asked about eating. If you eat green leafy vegetables, drink a lot of water, that kind of boosts your system a little bit. So.
Okay.
To the mom, one thing about sickle cell patients, I think we all may have it in common. When we're in a crisis, we don't want to be bothered. Right. The telephone ringing, anything that will startle you increases your heart, and that throbbing starts doing this. So we become kind of angry. So if ever, you get like attacked, but not attacked, it's nothing, meant toward you. It's just that there's absolutely nothing you can do. So don't ask questions and just let him be at peace and let him rest. One thing my parents used to do, though, that did feel good, they would massage whatever limbs were hurting, while I'm sitting in the old-fashioned metal tubs, of hot water, and they would massage me, but they wouldn't talk. They would just massage.
Silence. Okay, take the question over there, then we'll come through the front.
I have two boys as well that have sickle beta thalassemia. And what I've been experiencing, I was kind of told at the age 8 it would kind of stop, is bedwetting. I have my boys 11 and 8 now, and the bedwetting has gotten even worse. We wake up throughout the night. We've tried so many different things to stop, and I was just wondering, have you guys ever experienced that? Because I know other children that have sickle cell now, they're very close friends of mine. Their kids as well have experienced it, and I was hoping maybe you guys have a remedy that you can suggest because it's very out of control.
Ask another question that I've never experienced it in my, so I wouldn't be able to. Maybe one of the doctors.
Yeah, we'll let one of the doctors, Dr. Shurney.
I talked about how different children with sickle cell disease are, and I talked about the variability of the illness, but then I have to go back and say that one thing that's the same about children with sickle cell disease is that they drink and they urinate and they drink and they pee and they drink, and they're like, oh, all the juice is gone, and they went to bed. 75% of boys went to bed until they're 7 years old. Part of that is genetic, part of that is being boys, and part of it is sickle cell. Sickle cell, you don't concentrate your urine very well, so you're getting these huge volumes of urine. If you're in a pain episode, you're taking narcotics, and you're sleeping really hard, and then you're going to wet the bed. We have had some success with tofranil at a very small dose, which is actually an antidepressant, but at a small dose, it seems to help you to wake up a little bit better, to go to the bathroom. Waking kids, limiting fluids before they go to bed, which is really difficult because the kids sneak and then they go because they're thirsty, so they're going to get this water one way or the other. Got to protect you have practical things like protect your mattress, you know, and put the plastic on, and it's really important how you relate to that, so they know it's not because they're babies, it's because they have sickle cell disease, and then you're not chastising them for it. It's not because they're lazy. There's a real reason for it. And now there's an alarm system that you can attach to the sheets, and it senses when the sheets are wet, and it wakes them up as soon as they urinate. It's supposed to help them to kind of get adjusted to wake up. And I've had some success with that, but it's a very difficult problem.
How do you get the alarm system? Numerous amount of times, because I mean, I'm literally washing sheets,
right? I understand.
Comforters daily.
See me after the conference, and I'll hook you up.
Okay. Okay. Question right here, Coco.
It's for the entire panel. I know that I have a mother who has sickle cell disease, and I also have a teenage daughter. And I also work with the sickle cell disease community. And I know that a lot of patients who have high levels of stress, who have sickle cell disease, is often a trigger for your pain crisis. And I was just wondering, for the panel, how do you deal with stress?
I try to avoid it as much as possible. And it is true, stress is one of the number one factors that can trigger a crisis. And the thing about stress is silent. You really don't realize it, and then when you do, you try to deny it. You know, so it's just one of those things that you have to try to avoid, you know, as much as possible.
Is there a mechanism or something that you do to try to alleviate your stress?
I meditate and I pray a lot, so that helps my stress factor.
Can I put a plug in for this afternoon session? We're going to talk about some of these things.
Okay.
Okay. Anybody else want to answer to that question?
You pray a lot, you read a book, watch a movie, anything to distract you. Because the more you get stressed, your body tenses up and you hurt that much more.
Okay. Question here.
My name is Jennifer. Kind of one of the questions that were asked before about how different your experience with sickle cell has been in comparison with other persons. My mother has sickle cell. My aunt has sickle cell. My cousin has sickle cell. My best friend has sickle cell. My mother was diagnosed at 5 and was in and out of the hospital all of her life. So she's never lived beyond 25. My aunt was diagnosed as a small child as well and didn't experience the same complications. My mother could not go outside and play as where my aunts and uncles could. My aunt did not have a sickle cell crisis for 30 years, and then 2 years ago she died. My mother has had sickle cell crises all her life and is still alive. I have a cousin who turned 31 yesterday, and she has sickle cell, but she actually is on the list to get a kidney. She's gone through as much as my mother has. My mother and my aunt grew up with it, same house, and experienced it very differently. And so your experiences kind of seem like my aunt's experience, where my aunt modeled. My aunt had her own culinary business. She did a lot of things. She really thrived in spite of sickle cell, whereas my mother was constantly medicated, constantly in pain, and even told that she was a drug seeker. And I think it was kind of refreshing, one, to see the panel and hear your different experiences, but it kind of surprised me that all three of your experiences, and your son, how great you guys have done, because the people that I know have experienced it in a very traumatic way. So to kind of answer your question, that it is very different, because the 4 people that are in my life that I know that are very significant to me have experienced it very differently.
Question. Stillman.
I want to share some of my experience with relieving stress, because
Bless you.
I've almost become an expert at it, so forgive me if I say too much. But anyway, some of the ways I relieve stress is listening to real peaceful music, whether it's jazz or gospel. That really helps. Another thing that I did was a little odd, but this is what everyone has to do what they need to do. But I had a big, huge picture of Jesus on the cross. And when I couldn't pray no more and I didn't know how to pray no more, I'm so sensitive, I'm sorry. But oftentimes I would turn the light, there was a light on over the picture. So when I felt like, don't know what to say, don't know what else to say, I would turn that light on. And have, relationship with God, and, take the burden, help me with the burden, making sure. So everybody has to find their own way.
Question, babe. And then you, sir.
I have sickle cell. I was diagnosed at 9 months in 73, and they told my mother not to expect me to live to see 3 years old. And in that time, now I'm 39, but in all that time, between childhood and adulthood, one thing that would help me out was taking hot baths and like you said, having people massage wherever it was that was hurting and doing warm compress. As I got older, I realized I needed a membership to like the Y, or my wife and I would try and move to different places that had a jacuzzi. Because when I got in the jacuzzi, it alleviates the gravity, which takes pressure off your body and relieves pain. The heat helps, the jets help. I take less pain medicine, and I get over my pain crisis quicker that way. And I was wondering, I've lived in Indianapolis and I lived in Virginia, and I've researched other areas, and I people and telling health professionals if they were to make jacuzzis accessible in hospitals, the medical places, then we could be pumped with less pain medication and get over the pain crisis quicker, because I'm not the only one that does this. It works for some of everybody that I've talked to. And I was wondering, have you all heard of any medical professional ever or hospital that does have jacuzzis that will allow patients to use them or whatever? Have y'all heard of it?
I'm going to take a stab at it.
Yeah, go ahead.
So in New Jersey, they had a lot of jacuzzi in the hospital, not for sickle cell disease, but for burn patients and patients who had rheumatoid arthritis. The issue became the sanitation of the water and spreading infection. And so they kind of disbanded that. There is a concept of aquatherapy that you can get a prescription for, and if your insurance covers it, you can go to do water therapy at a gym or a physical therapy place. And we're beginning to use a lot more of that in Atlanta. Even though the weather is warm, we still have patients who are like you who need that. And then I recommend, if you can swim, learn how to swim, because swimming is another thing that may help. However, there's a pro and con with that. If you swim in cold water, you're not going to keep very well. But having it as a medical treatment in the hospital comes with a lot of regulatory issues around MRSA, around waterborne infection, and so it's a really good source of therapy, but it's very difficult to regulate it in a hospital setting, and you don't want to get that infection, because that's an issue too while we're treating your pain. However, this is something that if you tell your doctor that this is helping you, you can brainstorm around how to get the resource outside the hospital in the community. And I think people need to hear more from you guys about what helps. As a doctor, I only know this much about what's going to help you. And the more you inform your doctor what others have told you, what you've read about, then we can kind of come up with a way. Maybe there can be an in-between facility where when you have a pain crisis, you go there and do your aquatherapy as opposed to doing it in the hospital. These are all potential opportunities for the future, how to treat sickle cell pain. But that's a great suggestion, a great idea.
Yeah, those things that you can sit down on the side of the tub and jet ski things. You buy a couple of those.
Okay.
That'll help. I know what the jacuzzi feel like. I like it too.
Now, I think you had the question, sir, that you,
Yeah, I had a question.
and then we'll come up here.
Medical community, maybe y'all can help me resolve a little dispute between me and my daughter. Not dispute. You made a reference to diet and green leafy vegetables being productive as far as sickle cell comfort and just being overall good for a sickle cell patient. How important is the diet and nutrition when it comes to along with your niece and protein and stuff like that. So how important Dr. Hyman?
So I'm gonna take the human being approach. I forget that I'm a doctor. Okay, my children don't like to eat their vegetables, right? And they get constipated. They don't have sickle cell disease. So I'm buying Miralax and suppositories, and my toilet is being plugged up, and I gotta spend the money. And then I said, this is ridiculous. So I made it a rule: if you don't eat your salad, you're not gonna have any dinner. And I haven't had to call the plumber in several years. So if it's good for you without sickle cell disease, it's even better for you with sickle cell disease. And I think that general statement is true for whatever it is we're talking about. If drinking water is good for your zits and your constipation and your PMS without sickle cell disease, can you imagine how much better it's going to be for you when you have sickle cell disease? And so any child who doesn't believe in eating well, just don't, and then see what happens. That's the way I look at it.
So diet is
For human beings in life, diet is important. What you eat reflects what's going to happen to you.
Okay. You want to add to that? Okay.
Can I add to that? Because we actually had a conference about 2 years ago in IH about. So yeah, and you do have an increased risk of nutritional deficiencies beyond the normal population. So if you have two children who are the same and one has sickle cell and one doesn't, that one with sickle cell is at increased risk of certain vitamin deficiencies. And if you can talk to this, she did a vitamin C study, and there are other issues that express themselves more severely when people with sickle cell disease have these nutritional issues. So it's even more important for people with sickle cell disease to maintain adequate diet. And even with adequate diet, they still often will express these severe vitamin deficiencies. And so one of the things I've been trying to encourage my physician colleagues as they develop multidisciplinary practices around this disorder, because people often don't include nutritionists in that equation. But there needs to be more nutritionists focused on serving this population.
And Dr. Bell, did you want to add to that?
Yes.
And then we'll take the last question. Sorry.
I think that
They're still talking about the same question.
We're starting to get real science in the vitamin deficiencies in sickle cell. I know that Dr. Morris has, and we have a study at our hospital of increasing arginine in the diet, and giving arginine for people who have sickle cell crisis, and it seems to have helped. Nitrous oxide, certain things, foods and chemicals and nitrous oxide seem to help. So I think that the medical community is, looking at things that people have assumed from their diet, and now we're trying to get proof that what really helps people. And it looks like arginine is going to be one of the things that sickle cell people, a lot of sickle cell patients are low in and need to increase. And we're just in the infancy of this, but people are starting to look at vitamins and chemical compounds that will help people decrease their amount of crisis.
Okay. All right, we'll take our last question in the back.
Mine is not a question, it's just a couple of comments.
Okay.
These are the things that I have found that are good for my granddaughter. Number one is to make sure that she takes her medicine regularly. If she does have a crisis, and that's very seldom, she had one this year, and she hadn't had one in 5 years, and that was because she was not taking her medicine. Exercise has been found to be very good for her. I was concerned that she shouldn't play basketball or she shouldn't be in color guard, but while she is in these activities, she does very well. Swimming is excellent for her. I have found that basically a vegetarian fruit diet is very good, although she likes the noodles, the macaroni, those things that aren't really good for you. And taking a multivitamin daily.
Folic acid.
So those are the things that we have found over the last 14 years that have worked extremely well for Jacob, and of course following your doctor's directions.
Okay. Thank you.
Wow, that was great. Went completely through the time. Let's give our panelists a round of applause. Okay, we'll go ahead and have a 15-minute break, and this is when we'll do the breakout sessions. So if you're going to be getting CMEs, you'll come back here in about 15 minutes, well, a little less than 15 minutes, like 13. And then if you're going to do the community track, then you'll go over to room B.